dear President, dear colleagues. Let's talk about pulmonary embolism and is it necessary to perform an echocardiographic examination in all our patients presenting with PE. This is my closer. I have no conflict of interest to declare. And the study of the right ventricle is very difficult because the right ventricle has a complex form and it has a thoracic position. We have two major problems with the right ventricle, a common wall with left ventricle and also a problem of the proximal resolution of echocardiography. Furthermore, right ventricle have different properties as compared to left ventricle. Right ventricle has a tolerant diastolic function and can expand abruptly through a configuration change. Furthermore, it has a sensible systolic function and it adapts with difficulty to an increased load. Echocardiography has been proposed and validated in acute pulmonary embolism and is very useful only when we have a significant pulmonary embolism defined as a pulmonary obstruction higher than 30 or 40%, or when at least two lobar arteries are involved in this PE. The most typical finding is an acute cor pulmonale, defined as a right ventricular enlargement associated with a paradoxical septal wall motion, as you can see just here. We have different echocardiographic parameters to define a right ventricular dilation. The right ventricular and diastolic diameter, the right to left ventricular diameter ratio, and the right to left ventricular area ratio. In a previous work, we have demonstrated that the most accurate echocardiographic parameter to define the obstruction of the pulmonary arteries was the right to left ventricular area ratio with a ratio cutoff value of 0.6. And this measurement may be performed like that in apical four-chamber view and for the diameters in parasternal long axis view. It is also possible to perform the assessment of the regional right ventricular systolic function. In acute pulmonary embolism, there is a distinct regional pattern of right ventricular dysfunction with akinesia of the mid-free wall, as you can see here, and the normal motion at the apex. In patients presenting with primitive pulmonary hypertension, there is an akinesia of this apex and not found in acute PE. However, in routine practice, this study is sometimes very difficult because of poor echogenicity of our patients. When we perform an echocardiography, it is also important to assess the right pressures. And in case of an acute pulmonary embolism, and if it is a first event, there is a mild increase of pulmonary pressures. Echocardiography is very accurate for the measurement of systolic pulmonary arterial pressure by tricuspid regurgitation. When we don't have a tricuspid regurgitation, it is also possible to perform the measurement with a pulmonary regurgitation. When the measurement of the systolic pulmonary arterial pressure is not possible, we always have the possibility to perform the measurement of the acceleration time of pulmonary artery by the PW Doppler. And in case of PE, acute PE with a significant obstruction, we have a short acceleration time lower than 100 milliseconds. Finally, we can estimate the right atrial pressures using the inferior vena cava diameter and the variation of this diameter as recommended with the recommendation of the American Society of Echocardiography. Echocardiography allows to direct visualize thrombus, and according to the use of transthoracic echo, we can see the free-floating thrombus in the right heart or in the main pulmonary artery. TEE is also useful for the assessment of the thrombus in proximal or lobar pulmonary artery. Finally, the venous ultrasonography is useful for the assessment of deep venous thrombosis of the lower limbs. And the goal of this study is to perform the diagnosis of thromboembolic disease. We can combine this ultrasound strategy with echocardiography and venous ultrasonography. And in case of acute dyspnea, defined as a mainly proximal PE, there is a high sensitivity and a high negative predictive value, and this combined strategy is accurate for the strategy of PE. However, in patients presenting with a suspicion of PE and chest pain, reflecting distal pulmonary embolism, this strategy is not clinically relevant. Let's talk about one example of a man of 65 years old. He was addressed in our intensive care unit for a suspicion of acute PE. The clinical presentation is simple: dyspnea, high heart rate, and a low blood pressure, and a recent journey in Australia. Are you agree that's the suspicion of pulmonary embolism? I think so. At admission, we perform an echocardiographic examination to have the diagnosis, and we exclude the diagnosis of pulmonary embolism because this patient presented with a tamponade and a swinging heart. So echocardiography is able to perform other diagnoses, not only PE, but also other important diagnoses. We have seen the ultrasound possibilities. We have also other imaging with irradiations, the CT scan, the ventilation perfusion scan, and this technique had a problem. In most patients, we need additional testing because when we perform this examination, in most cases, the answer is clear, intermediate probability. We cannot conclude if there is a diagnosis of PE or if the diagnosis of PE is excluded. Pulmonary angiography was the gold standard, but is invasive, is not yet performed. We have also new imaging, such as MRI. But however, this technique have low sensitivity except for proximal PE, and in routine practice, we cannot propose this MRI to rule out pulmonary embolism. This last decade, we have significant modification concerning the strategy of our diagnostic imaging possibilities. Now, there is an emergent strategy with CT scan, the fall of scintigraphy, and the death of pulmonary angiography. And in more recent article, is the same finding with the examination of choice, which is CT scan. Why CT scan is now so important in routine practice to perform the diagnosis of PE? This is an accurate method for the diagnosis of PE, but also is very important to exclude the diagnosis of pulmonary embolism. We can also quantify the pulmonary obstruction using the Kennedy index. And when we have a low obstruction, we don't have any right ventricular dilation, and when we have a significant pulmonary obstruction, we have acute cor pulmonale. So this is a validation of pulmonary obstruction as the index Miller for pulmonary angiography. It is very important, of course, to look at the pulmonary arteries when you perform a CT scan. However, don't forget the right heart. Why? Because you can visualize a free thrombus in the right heart. As you can see here the thrombus who says hello. And with the CT scan, we have the thrombus just here. If you find a thrombus in the CT scan, perform immediately an echocardiography to confirm this diagnosis of thrombus. Also, you can assess the prognosis of our patients presenting with PE. And in case of right ventricular dilation by CT, the prognosis of our patients is worse as compared to patients presenting with a normal right ventricular size. And the question is, which parameter should we use? You can use the ratio between this diameter and this one, the right to left diameter ratio, or you can use also the right to left area ratio. So, CT scan is validated for the diagnosis of PE, for the exclusion of PE, for the quantification of obstruction, for the visualization of thrombus, and also for the prognosis of our patients. We had a previous classification of PE with two groups of patients. Patients with massive PE, defined as a shock or hypotension. This is a clinical definition. And we have non-massive PE with a subgroup of patients with echocardiographic abnormalities. This is the submassive PE. This classification is now over. And we have a recent new classification with the strongest marker, which is a clinical marker, shock or hypotension. And we have also markers of right ventricular dysfunction assessed by echo, by CT scan, and by BNP. And we have markers of myocardial injury. This is a troponin. And it's very important to perform this classification because now we have also two groups of patients, not massive, or massive is finished, but we have a high-risk pulmonary embolism, defined as a clinical definition, shock or hypotension, and a non-high-risk PE, and we have an intermediate group of patients of PE with no shock, no hypertension, but right ventricular dysfunction and or a myocardial injury. Why is it so important to perform this classification? Because the diagnostic imaging strategy may differ between patients presenting with a suspected high-risk PE and a suspected non-high-risk PE. In case of suspected high-risk PE, defined as a shock or hypotension, do immediately a CT scan. If it's possible, do it. Positive, this is a pulmonary embolism. Negative, no PE. If you cannot perform this examination, perform an echocardiography to look for a right ventricular overload. If you have this right ventricular overload, perform the CT scan. Not possible? It's not a problem. You can perform a TEE or a venous ultrasonography to perform the diagnosis of thromboembolic disease. If echocardiography is normal, this is not a pulmonary embolism because we have a significant pulmonary embolism if we have a patient presenting with shock or hypotension. What about the patients presenting with a non-high-risk PE? No shock, no hypertension. We have to think about the clinical probability of PE. If you have a high clinical probability, perform the CT scan. It's a low or intermediate probability, perform the dimers. Positive, CT scan. Negative, this is not a pulmonary embolism. There is no place for echo in this diagnostic strategy. Finally, concerning the treatment, we have three groups of patients. First, a low-risk PE with no shock, no hypertension, no right ventricular dysfunction. And we have also patients presenting with shock. For these two groups, it's very simple. Heparin anticoagulation for this first group with a low-risk PE, and for patients with a high-risk PE, this is thrombolysis. What about the patients presenting with an intermediate risk PE? Is it necessary to perform a thrombolysis? I'm sorry, but I don't have the answer today. It's still debated. However, in a previous study, look at the rate of death. It was very low, 3% concerning thrombolysis versus 2% with heparin. No differences. And the only parameter in favor of thrombolysis is that patients who had a previous thrombolysis had few second thrombolysis as compared to patients without a previous thrombolysis. So it's not possible to answer to this question, but in our institution, we do not perform thrombolysis in this group of patients. Finally, what about patients presenting a free-floating thrombus, representing about 3.5% of our patients with PE? Be careful that we can have some potential mistakes, artifacts of right ventricular trabeculations. Be aware that it's not a trabeculation. And if you have a free-floating thrombus, this is associated with high-risk PE, and we need to perform an aggressive treatment, thrombolysis or surgery. There was no previous prospective study, and in a meta-analysis, we can see that surgery or thrombolysis is better than no treatment or heparin. And this is an example. You can see here the thrombus in the right atrium. 90 minutes after the thrombolysis, no more thrombus, but a major right ventricular dilation. And 12 hours after, there is a normalization of the right ventricle. In conclusion, is echocardiography necessary for all our patients presenting with pulmonary embolism? The answer is clear, no. However, echo is useful in case of significant pulmonary embolism. And also, it allows to perform other diagnoses. We have a recent ESC classification in pulmonary embolism with two groups of patients, high-risk PE, presenting shock or hypotension, and non-high-risk PE. And we have a subgroup of patients with an intermediate risk, and is defined according to echo, biomarkers, and CT scan results. And CT is now the examination of choice and allows to completely assess pulmonary embolism. Thank you.